Hello. Okay. Hi, good afternoon. So today we'll be continuing with the part 2 session of the lecture on neuroradiologic anatomy, focusing on the spine. So in part 1, we've covered thoracic spine and lumbar spine. I'm sorry, we've covered craniovertebral junction and subaxial spine. So this lecture was dedicated to thoracic spine and lumbar spine. I was also hoping to be able to cover sacrum and coccyx, but this lecture has itself become quite long with just these two. So we'll have to cover this in a different lecture another time. Right, so we'll start off with the thoracic spine. Similar to the concepts we learned last week with reference to subaxial spine, it's more or less a similar idea. So, how these vertebral levels, these vertebral segments arise is basically through three ossification centers. There's a centrum, there's a left and a right neural arch. Between this, you've got the synchondroses. You've got the posterior synchondrosis between the two neural arches over here, and then you've got the neurocentral synchondrosis between the centrum and the neural arches. Right, so in the thoracic segments, the posterior synchondrosis will close by 2 to 3 postnatal months, and in the neurocentral synchondrosis, these will close from a rostral to a caudal fashion. So they will start at the T1 level and then they will start closing down below. And this begins at a much later age of about 5 to 6 years. And in adults, some of these centers may actually still be unfused. Right, so as we can see in the newborn, the neurocentral synchondrosis is completely open, it's not fused, and the posterior synchondrosis is also not fused. By 1 year, there is some fusion of the posterior synchondrosis, and the neurocentral synchondrosis is still not fused. By 5 years, the neurocentral synchondrosis has started fusing, and the posterior synchondrosis has fused. At 18 years, most of the neurocentral synchondrosis would have fused, but it is possible that even in adults, some of these neurocentral synchondrosis have still not fused. But the posterior synchondrosis should have definitely fused. Right. So coming to the osteology of these segments, actually there are only T2 to T8 thoracic segments which are typical. Otherwise, the other thoracic segments are not exactly typical, even with the vertebral body. So only T2 to T8 segments are typical thoracic segments. T1 segment, on the other hand, isn't exactly a typical thoracic segment. It's a little bit more towards the cervical vertebra, especially with this uncinate process. It also has the most cervical configuration. While from T8 below, that is T9 to T12, you get a little bit of the lumbar transitional feature. So as we can see over here, these are the uncinate processes sticking out from the T1 vertebra, which should not technically be present here. As we know that the primary curvature of the cervical spine was lordosis, of the lumbar spine is also again lordosis, but that of the thoracic spine is thoracic kyphosis. Now, in the cervical spine, the main configuration of the lordosis was coming through from the intervertebral discs and not from vertebral bodies. But thoracic kyphosis mostly arises because of the vertebral bodies. It is because the vertebral bodies are wedge-shaped. Okay, so the posterior height of the vertebral bodies will be longer than the anterior height, and that is why there is a thoracic kyphosis and not because of the intervertebral discs. The vertebral bodies also are more in dimension in the lateral width than in the AP width. They also have a dorsal midline concavity, and that is why when it comes to thoracic spine, the vertebral body looks like an upside down heart. The pedicles of the thoracic vertebra, they arise from a much higher position than in other levels of this spine. So they arise from a more superior position as compared to the cervical and the lumbar vertebrae. They are also longer and broader than the cervical pedicle. So as you can see over here, the C7 pedicle is narrower, but the T1 pedicle is quite broad in comparison. The typical vertebrae, that is T2 to T8, will not have superior vertebral notches. As you can see over here, the T2 pedicle does not have a superior vertebral notch, but the T1 pedicle actually has a deep superior vertebral notch. And even the T10 to T12 pedicles might have a superior vertebral notch. But overall, in the typical thoracic vertebra, there should be no superior vertebral notch. But there will be deep inferior vertebral notches present for sure. Now the pedicles are ovoid shaped. So if you look at this coronal section, they are going to be longer in the sagittal plane than they are in the transverse plane. So they are ovoid shaped. So we have the vertebral body, and then from the vertebral body we have the pedicle arising over here. And at the junction of the pedicle and the lamina, that is where the transverse process arises. So as you can clearly distinguish this from a cervical vertebra, as we can see over here. In the cervical vertebra that we have seen in the previous lecture, you have the vertebral body, and then between the junction of the vertebral body and the pedicle, that is where you get the transverse process. Okay, and then you get the pars and the lamina. But here, in the thoracic vertebra, you have the vertebral body, then you have the pedicle, then at the junction of the pedicle and the lamina, that is where you get the transverse process. The transverse processes are going to arise more posteriorly, as we saw. So they arise posterior to the facet joints and to the pedicles. They are broader, and as you can see, significantly larger and longer than whatever we were having in the cervical vertebra, and they're directed posterolaterally. This length of the vertebra the transverse processes will decrease as we go from T1 to T12. So T1 will have the largest and the longest transverse process. They also have small facets anteriorly, as we can see over here, so they can articulate with the rib tubercle, forming the costotransverse joint. At the same point where the transverse processes are arising, you also have the pars interarticularis. So the pars interarticularis gives rise to a superior articular facet and an inferior articular facet. The facet joints, when it comes to the thoracic vertebra, are actually oriented coronally. So if you were to see, for example, an X-ray or a CT, you'll have one articular process like this and another articular process like this. Okay, so they'll be oriented coronally, while in the lumbar vertebra, they're oriented sagittally. So you'll have one articular process like this and the other one on the outside. So that's how we can differentiate between a thoracic and a lumbar facet joint. Now the superior articular process will arise at the junction of the pedicle and the lamina, and as we can see, they will face posteriorly to then articulate with the inferior articular process over here, which will arise from the lamina, and as we can see, it is facing anteriorly. The laminae, when it comes to thoracic vertebrae as compared to cervical vertebrae, are definitely thicker and they have more height, as we can see over here. But they are a little bit shorter in the AP dimension though, but they are definitely going to be thicker and longer. Because the laminae are so long, there are like very narrow interlaminar spaces, and it is very difficult to get into these spaces in the thoracic spine. Sometimes these laminae can have very small, tiny spicules which arise from the anterior and the inferior margins of the laminae. This is a site where there's a lateral attachment of the ligamentum flavum. These are called para-articular processes, and they're normal imaging findings and should not be considered as an ossification of the ligamentum flavum. Spinous processes, when it comes to the thoracic vertebrae, are rectangle shaped and they're elongated. So they are longer than what we are expecting to find in the cervical vertebrae, and they are rectangular in shape. The T1 to T4 spinous processes will be arranged horizontally, but as we go below that, the spinous processes are oriented all inferiorly. But as we come to the T11 and T12 vertebrae that we can see over here, these become more and more lumbar. They again become more square and more horizontal. Now, we know that within the thoracic vertebrae, T2 to T8 vertebrae are considered as typical, while the other vertebrae are more or less transitional vertebrae. So in the T1 vertebra, you have these transitional phenomena of the uncovertebral joints, as we saw over here, as well as this deep superior vertebral notch. The vertebra is also more rectangle in shape, just like the cervical vertebrae. T10, T11 and T12 vertebrae are also transitional vertebrae, and they have slightly different features as compared to our typical thoracic vertebrae. So the typical thoracic vertebra, the rib head would articulate with the vertebral body. But as we can see in the T10, T11 and T12 vertebrae, the rib head keeps articulating more posteriorly. It starts articulating with the pedicle as we go on between T10, T11 and T12. The T12 vertebra also has, as we can see, a very small transverse process, and it actually has a mammillary process. That is something we should only find in the lumbar vertebra, but at T12 we can also find this mammillary process. Right. So coming to the facet joints, as we have discussed already, the facet joints in the thoracic vertebrae should be coronally oriented, and as we can see, they should be horizontal in the thoracic vertebrae. Now, the facet joints are going to be slightly more vertical than the cervical ones. As we can see, the cervical ones would have been slightly oriented, for example, at this angle, but the facet joints of thoracic vertebra are oriented more vertically. Okay, and anytime you see the axial images, there will be a facet which is located anterior to the joint and a facet posterior to the joint. So the superior articular facet will always be anterior and the inferior articular facet will always be posterior. The main function of the facet joints in the level of the thoracic spine is to allow axial rotation but restrict flexion extension and lateral bending. At the T12 level, the facet joints start transitioning into a more lumbar orientation. So this is the facet joint between T11 T12, and as we can see, it is clearly like a normal thoracic facet joint. At the T12 L1 transitional level, you can see that the facet joints become more sagittally oriented as compared to being coronally oriented. Right, so as we know, the thoracic vertebrae is significantly stabilized because of the attachments it has with the rib. So there are two attachments that it forms with the rib. There is a costovertebral joint between the rib and the vertebral body, and there is a costotransverse joint between the rib and the transverse process. We have already seen the costotransverse joint. The costovertebral joint is formed between the rib head, as we can see over here, and two demifacets which are present between the superior and the inferior end plates between two vertebral bodies. Right, so as we can see, there's a superior demifacet over here located at the inferior end plate of the superior vertebra, and an inferior demifacet over here located at the superior end plate of the inferior vertebra. Now, at the level of T10, T11, T12, and at T1, there are no demifacets, there's no half facets over there. They have single ovoid facets, and the rib head articulates only with one vertebra over there and not with two. So in this coronal section, we can see over here, this will be the superior end plate and the inferior end plate of the vertebra, and as we can see, the rib head is articulating with the superior end plate through a demifacet here, and with the inferior end plate of the vertebra above through another demifacet here. So that was a costovertebral joint being formed between the rib head and the vertebral body over here. There's also a rib tubercle lying more posteriorly, which forms another joint with a facet which is located on the transverse process, that is the costotransverse joint. This costotransverse joint might sometimes need to be traversed to basically reach areas like the neural foramen at times. So percutaneous access might actually end up going through this costotransverse joint. Right, now coming to a little bit more soft tissue anatomy. So as we've already discussed a lot of these ligaments, we'll just go through them again. More or less a similar ligaments as we saw with the subaxial spine. You have the anterior longitudinal ligament, and in the cervical and lumbar regions, it is going to be thinner. The thickness is greatest at the vertebral body levels, normally with the ALL, and it is going to be thinnest at the disc levels. So sometimes the ALL can get ossified, and then you can make out this ossification of the ALL in some cases, which really isn't that significant. More importantly is the posterior longitudinal ligament. It is attached, as we know, at the superior and the inferior vertebral margins and at the disc level. It is going to be broader at the level of the disc and narrower at the level of the body. So that gives it a slightly denticulate configuration. So it just fans out like this at the level of the disc and becomes narrow at the level of the vertebral bodies repetitively, giving it a teeth-like configuration. Okay, so the ALL and the PLL both have multiple layers. The PLL has superficial and a deep layer, and the superficial layer is the one located more posteriorly. And sometimes the PLL can get ossified, forming OPLL, which can cause compression of the spinal cord. Another important ligament is the ligamentum flavum. The ligamentum flavum extends from the posterior superior margin of the lamina below to the anterior surface of the lamina above. So there's multiple, so every single level has its own ligamentum flavum. There are lateral extensions of the ligamentum flavum which will form medial capsule of the facet joint. So it extends around here and gets attached to the medial capsule of facet joints, and as we can see over here, it has become ossified. The thoracic ligamentum flavum is again going to be thicker than the cervical ligamentum flavum. You also have the other ligaments, the interspinous ligaments and the supraspinous ligament. Right, so this area is supplied predominantly by the thoracic aorta, and from this you get 9 pairs of posterior intercostal arteries which will form the segmental arteries. You also get one pair of subcostal artery to supply the T12 vertebra, and you also get supply from the costocervical trunk, the aorta of the vertebral arteries for the first 2 vertebra through the superior or the supreme intercostal artery. So these vessels, as we can see over here, this is the posterior intercostal artery. They will run and they will form an anterior ramus, and that will supply the intercostal space, and a posterior ramus. The posterior ramus gives rise to a muscular branch and a spinal branch. The spinal branch is going to enter through the neural foramen and form the anterior and posterior radicular arteries. If these radicular arteries are also supplying the spinal cord, it will form the radiculomedullary arteries. The most important radiculomedullary artery, I think everyone is already aware of, is the artery of Adamkiewicz. So this is the dominant artery which supplies the lower part of the spinal cord, and it is most likely to arise between the T9 to T11 segments on the left side. But it can go up as high as T5 or even as low as T3. A characteristic way to identify it on angiography is this hairpin turn that it makes to join the anterior spinal artery. Venous anatomy is more or less similar to what we discussed with subaxial spine. There's an intrinsic network which drains the spinal cord parenchyma, an extrinsic network running on the surface of the spinal cord, and an extradural network. So intrinsic network is going to be draining the spinal cord gray matter and white matter. The extrinsic network is a network which is formed on the surface of the spinal cord. So you have the coronal venous plexus, and then you get the radiculomedullary veins. These radiculomedullary veins will then get out and then drain into these extradural systems. You have the anterior and then the posterior internal vertebral venous plexus located within the spinal canal. And then outside that, outside the vertebra and the laminae over here and the spinous process, you get the anterior extradural anterior external extradural vertebral venous plexus and the posterior external extradural vertebral venous plexus. So how does it drain overall, and where does it go? Where does the blood go? So from the intrinsic system draining the spinal cord, you go into the extrinsic system, that is your radiculomedullary veins. From that you go into the extradural systems, and from that you are able to enter the basal vertebral veins, as you can see over here, supplying the vertebral bodies. From that it drains into the posterior internal vertebral veins present over here. These posterior internal vertebral veins are going to drain into the azygous vein on the right side and into the hemiazygous and accessory hemiazygous vein on the left side. Right. So coming to other soft tissue anatomy, we already know that about this meninges and the spaces. We've discussed them already in subaxial cervical spine. But there are a few changes when it comes to thoracic spine. The spinal canal is going to be narrowest at the mid-thoracic region, but it doesn't really significantly affect the cord because the cord will also narrow here. It is the area between the cervical enlargement and the lumbar enlargement, right? But because of the thoracic kyphosis, the cord does shift a little bit anteriorly, and that is why the dorsal subarachnoid space is always going to be more than the ventral subarachnoid space. As compared to cervical spine, there are thick epidural fat pads located in the dorsal spine and the lumbar spine. They're not very obvious in the cervical spine, but they're going to be obvious in your dorsal and lumbar spine. Okay, coming to the spinal cord anatomy itself, we know that there is going to be a central canal which runs through the spinal cord, but as we age, this central canal does tend to occlude. And this occlusion usually happens within the dorsal spinal cord, usually at the T6 level. In 1.5% of individuals, the central canal may persist and it may be seen in an MRI. Right, so the spinal cord gives rise to nerve roots which are going to exit at foramina which are present below the level of the vertebrae from which they have risen. As we saw with cervical spine, you have to add one level to get the level at which the nerve root will exit. For the thoracic spine, the T1 nerve roots will arise at the C7 level. The T2 nerve roots, on the other hand, will arise 1.5 levels above, and from T3 to T12, the nerve roots will arise about 2 levels above that. Right. So a few questions. Can you identify the following structures which have been hidden in this X-ray of the thoracic spine? So we'll discuss these one by one. So what would this be? We'll put down the answers in the chat box. Okay, so this is at the C7 and the T1 levels, and it is located at the lateral aspect of the vertebral body, and it is pointing up here, as we can see. So these are the uncinate processes. These, as we have seen already, will also be present at the T1 vertebra. Okay. So next, what are these? So this is the midline. So these are the spinous processes of that particular vertebra. The third thing is, what are these structures? Okay, so these round, very obvious structures are pedicles. Okay, so this is on usually when we're doing surgery, when you're trying to put a pedicle screw. These are the structures we look for on an AP X-ray. So these are pedicles. Okay, so now coming to the lateral view. What is this? Okay, so this, as you can make out, this would be the pars interarticularis. This is the inferior facet. This is the superior facet. And so this is the facet joint. What is this structure hidden here? So here we can more clearly see this facet joint over here. So this structure between the vertebral body and the facet joints would be the pedicle. Okay, and what is this last structure hidden over here? Yeah, so this is the inferior vertebral notch of the pedicle. So this is the neural foramen through which the nerve root will pass. At the level of T12L1, which nerve root should pass through here? Right, so it'll be T12. At the cervical level, the nerve roots will pass above their particular vertebra, but below the cervical level, the nerve roots will always pass below their particular vertebra. Okay, so next, can you identify this? What are these structures? Because this is the articulation between the transverse process and the rib tubercle. So this is the costotransverse joint. And we can see the costovertebral joint, the articulation between the rib head and the vertebral body over here. Okay. So, in this axial image, we know this is the facet joint and this is horizontally oriented. This is the thoracic facet joint. So, between both of these, in this more anterior structure, is it the superior facet or is it the inferior facet? Okay, so this is the superior articular facet of the vertebra below, while this is the inferior articular facet of the vertebra above. The superior one will be anterior, while the inferior one will be posterior. Okay, now coming to some MRIs, can we identify what are these structures? Okay, so this is a T1 image, as we can make out the CSF is hypointense over here. Okay. In a T1, in any image, T1 or T2, ligaments will always appear hypointense. As you can see over here, the ALL is hypointense, the PLL is hypointense, the ligamentum flavum is also hypointense. But fat is going to be hyperintense on T1. As we can make out, the subcutaneous fat is thoroughly hyperintense over here. So this is the interlaminar epidural fat pad. As we discussed, it is quite obvious in both thoracic and lumbar spine. Okay, so now let's discuss lumbar spine. There are a significant number of similarities and differences when it comes to thoracic spine. So we'll just focus on those differences importantly. So again, you have three primary ossification centers, one centrum, two neural arches, the same neurocentral synchondrosis and interneural synchondrosis. The differences when it comes to lumbar spine, the posterior synchondrosis will of L1 to L4 will fuse early. They will fuse by 1 year of age. The posterior synchondrosis of L5 might not fuse up to 5 years of age on the other hand. Sometimes there can be like a spina bifida like defect present at L5 and we should not consider that abnormal at least up till 5 years of age. Okay, the neurocentral synchondrosis on the other hand will achieve 75% closure by 4 years of age and complete closure by 10 years of age. So when it comes to lumbar spine, the primary centers should have fused by 10 years of age. So as we can see over here, in a newborn, the neurocentral synchondrosis and the interneural synchondrosis, nothing is fused yet. By 6 months, the posterior synchondrosis has fused, but the neurocentral synchondrosis is still not fused. By 2 years, we know some fusion would have occurred. And we know should definitely have fused by 10 years. So this is a picture at 10 years. And by 18 years, definitely all the centers should have fused. Right. So the thing with development is that actually the primary curvature of the spine is a kyphotic curvature. So in utero, the entire spine is more or less kyphotic. So the secondary curvatures of cervical lordosis and lumbar lordosis develop much later. Cervical lordosis develops when the child is able to hold and lift their own head. Lumbar lordosis develops when the child is able to walk upright. So we know there are two lordotic curves. There's a cervical lordosis and a lumbar lordosis. And lumbar lordosis is a lot more significant than cervical lordosis. And unlike the cervical level, it results from both the vertebral bodies and the intervertebral discs. So lumbar vertebral bodies are going to be taller anteriorly than they are posteriorly. And they're also going to be greater in the transverse dimension than the AP dimension. L1 to L4 vertebra have a dorsal concavity, as we can see over here, and that is why they are a kidney shoe shaped. L5 on the other hand is a more convex dorsal surface, so it is more elliptical. Right, so from these vertebral bodies, the pedicles arise, as we saw with other levels of this spinal canal. The lumbar pedicles are shorter, as you can see over here, again, than the thoracic pedicles. But they are definitely larger in height and width than the thoracic pedicles are. They arise a little bit more inferiorly from the vertebral body than the thoracic pedicles will. So as you can see, there is some space over here. So again, the lumbar vertebrae also have a superior vertebral notch. And the pedicles are arising slightly more inferiorly than they would on the thoracic spine. So you have a superior vertebral notch and you have an inferior vertebral notch, giving rise to the neural foramen. The pedicles, as we can see over here, and this is important for fixation also, they will angle superiorly at the level of L1, but as you go down because of the lordosis, they will start angling inferiorly at the level of L5. So at the junction of the pedicle and the lamina, the transverse processes arise. So this is sort of similar to what we have with the dorsal spine. The transverse processes here aren't as important because they do not articulate with the rib over here. So the transverse processes are not exactly round, they're a little bit more flat. They are though oriented posterolaterally. They will increase in length from L1 to L3 and then again start decreasing in length. The important thing over here is that there is an accessory process, as you can see over here, which arises usually at the junction of the transverse process and the lamina. So you have an accessory process here. Then you have the superior articular process over here arising at the junction of the pedicle and the lamina. The superior articular process also has a tubercle which arises posteriorly. That is a mammillary tubercle. So you have an accessory process and you have a mammillary tubercle over here. This notch between both of them is the mammalor axillary notch. The laminae of these vertebrae usually are going to be flat and broad. The superior and the inferior margins of these laminae are usually concave, so they have a significantly large interlaminar space as compared to dorsal spine. The L1 to L1, L2 to up to L3, L4 interlaminar spaces are going to be about similar in size. But when it comes to L4, L5 and L5S1, they are going to be much larger than the interlaminar space that we got above. At the junction of the pedicle and the lamina, the pars interarticularis arises. The pars is very significant when it comes to lumbar spine, okay, because of the significant amount of stress that is placed on the lumbar spine, trying to hold the weight of the entire spine and the skull. You can get a lot of stressors being placed on this pars interarticularis, and usually there tends to be a fracture which develops at these levels, most commonly at the L5 level, but also can happen at the L4 level. The best way to identify the pars interarticularis is to take an oblique X-ray. Okay, so you take an oblique X-ray and you're able to identify something known as a Scotty dog appearance. So if you look over here, we'll draw it out for you. So this is the face of the dog. This is its ears. This is the body, the tail, and the legs. Okay, and here you will get the eye. So this eye is basically a pedicle. So as you can see over here, this eye of the Scottish dog is the pedicle. Okay, and so this right, so you get the pedicle over here, and then you get the facet joints over here posteriorly. Okay, and this area is where you will get a defect in the pars interarticularis in cases of listhesis. The pars then also gives rise to a superior and an inferior articular process, and as we have discussed, the facet joints of the lumbar spine will be arranged sagittally. So as you can see, they are arranged vertically like this. Okay, so there's a process which faces laterally, and there's a process which faces medially. The process facing laterally is your inferior articular process. The process facing medially is your superior articular process. So these two join to form a sagittally oriented facet joint at the level of lumbar spine. As we discussed, the superior articular process also gives rise to a tubercle posteriorly, which is known as a mammillary process. You have the mammillary process, you have the accessory process, and in between them, you have a notch known as the mammulo-accessory notch. The last part would be the spinous processes. The spinous processes, unlike what we saw with dorsal vertebrae, are just very short and stubby. So they are broad, they are flat, rectangular, and just project horizontally posteriorly instead of projecting downwards like they were doing at the mid-thoracic level. Okay, so a very common anomaly we might find sometimes is known as the lumbosacral transitional anomaly. So what happens here is that sometimes the L5 vertebra can become incorporated into the sacrum, so that is known as sacralization, and sometimes the S1 can start displaying more lumbar-like features. It can become more lumbar vertebra. So the main problem is when it comes to labeling these vertebra, we can get slightly confused. Right, so these variants are found in populations ranging from 4 to 35%, and they can be slightly confusing. Now, there was a classification system proposed which tells you as to how much sacralization of a lumbar vertebra can happen. So in type 1, you can get just a dysplastic triangular process. This, on the other hand, is a picture of a type 2, where this transverse process is actually trying to form a joint with the sacral ala. If a bony fusion happens between the transverse process and the sacral ala, that is a type 3. A type 4, on the other hand, is where you have one side, there's a joint which is formed, and the other side, some bony fusion has happened. More important than knowing the type of classification of these vertebra is how do we count them? Like, how do you know that this is L5 or this is L5 or is this L5? So that's where confusion can happen. There's only one way to be absolutely sure. You have to count it from the top. Okay, so a whole spine X-ray, a whole spine CT, or a whole spine MRI, go up to C2 and start counting from there. It does not make any sense to try to figure out from below if this is L5 or not. Right. A very important area when it comes particularly to the lumbar vertebra is what is the lateral recess. So when it comes to the spinal canal in the in the lumbar vertebra, it is more triangular in shape. In other places, it's thoracic and cervical, it's more round, but with lumbar vertebra, it's more triangular, and these triangles and their apices here form the lateral recess. Now, the lateral recess is going to be bounded by the thecal sac medially, but laterally you have the pedicles, as we can see over here. You have the vertebral body and the disc anteriorly, and then you get the superior articular process posteriorly. Now, in the lateral recess, that's where you will get some nerve roots. The nerve roots of the chorda equina mostly will be running in the center, but the nerve which has to exit in the neural foramen below will be running in the lateral recess. Okay, so if you're talking about the lateral recess at the L4, L5 level, at the lateral recess, you will usually get the L5 nerve root, which is known as the traversing root running through. Right, so these transiting nerve roots will be running from the thecal sac into the neural foramen, and they'll be running with the sleeve of the dura. So that is, they have a dural sleeve through which they're running. And when there's a degeneration of the superior articular process, it can impinge on these nerve roots and cause something known as lateral recess stenosis. So whenever that happens, there's always going to be symptoms which are going to localize to the traversing root and not to the root which is going to exit at that level. So for example, at L4, L5 level, if you get lateral recess stenosis, the stenosis is going to affect L5, which is a traversing root, but not L4, which would be the exiting root. Right. So the nerves will traverse from the thecal sac into the lateral recess and then out through the neural foramen. The neural foramen is going to be largest at the level of L1 and then decrease in size as you come down to the L5 level. The L1 to L4 level neural foramina are keyhole shaped. There's a larger superior compartment which is oval and then a more ovoid inferior compartment. But the L5 S1 foramen is not exactly keyhole shaped, it is more shaped like an upside down egg. The nerve root runs through the superior component of this keyhole shape. Right, so there's a superior component and there's an inferior component of this foramen. The superior component is bounded anteriorly by the vertebral body, superiorly by the inferior vertebral notch, and posteriorly by the inferior facet. On the other hand, the inferior component is bounded anteriorly by the disc, inferiorly by the superior vertebral notch, and posteriorly by the superior facet. Right, so between the vertebral bodies, we have the disc. The disc, as we know, has a nucleus pulposus and an annular fibrosis. So it has an annulus fibrosis on the outside. The nucleus pulposus appears hyperintense, and the annulus fibrosis, which has more collagen content, is going to appear hypointense on MRIs. Right, so this clear-cut differentiation is usually present in early ages, usually up till 30 years of age. We know that lumbar lordosis is provided by the intervertebral discs also. So the discs are going to be taller anteriorly than they would be posteriorly. And when it comes to lumbar discs, they are the tallest within the spinal canal, and they have the most weight-bearing ability. These appearances will change with age. At early age, as we saw, you can clearly differentiate between the nucleus pulposus and the annulus fibrosis. But as age proceeds, that differentiation will start coming down. By the third decade, you will start seeing this line running through the nucleus pulposus. And this is known as the internuclear cleft. And when it comes to the 8th to 9th decade, you will not be able to differentiate between the nucleus pulposus and annulus fibrosis at all. Ligaments, as we've already seen, are similar to what we've discussed previously. There's the ALL, the PLL, the ligamentum flavum. And remember, ligaments will always be hypointense. So as we can see over here, this is the ALL. You can clearly make out the ALL continuously over here. But as you can see with PLL, you cannot make it out continuously. There's an area where it is not seen. So this is the discontinuation between the PLL to allow the passage of the basivertebral vein. Okay, so PLL is very thick and intact around the level of the intervertebral disc, so that really helps prevent protrusion. And it is not very thick or strong here at the level of the vertebral bodies where the basivertebral veins will enter. This, as we can make out, is the ligamentum flavum. And the hyperintense areas in front of it are the interlaminar epidural fat pad. Okay, so this is supplied by arteries which arise from the aorta. Again, they're the segmental arteries. The L5 artery might arise from the median sacral artery or sometimes the iliolumbar trunks. As we have discussed previously, the segmental arteries will give rise to an anterior ramus and a posterior ramus. The anterior ramus will supply the body wall, and the posterior ramus will form a spinal and a muscular branch. The muscular branch will supply the paraspinal musculature, while the spinal branch enters the spinal canal through the neuroforamen and forms anterior and posterior radicular arteries. If they supply the spinal cord, also known as radicular medullary artery. So we've already seen artery of Adamkiewicz can sometimes arise at the lumbar level also. That will be rare, but if it does happen, it can be up till L2. Right, so and they go in, they form the radicular and radicular medullary arteries, which go in and reinforce the anterior and the posterior spinal arteries. These anterior and posterior spinal arteries get together around the level of the conus, and they form an arterial basket over here, which is an anastomotic basket, and that is known as a basket of Lazarthus. The venous system is again more or less similar. You have an intrinsic system which drains the spinal cord parenchyma, an extrinsic system running on the spinal cord known as the vasa corona, and then you have the extradural system. The extradural system is, as we have already seen, there's an internal vertebral venous plexus which is anterior and posterior, and there's an external vertebral venous plexus which is again anterior and posterior. This will all drain through the basivertebral veins into the segmental veins, which will then finally drain into the azygous vein. There's an important vein which is located at the level of the lumbar region usually, that is known as the great anterior radicular medullary vein. Now, this is the largest vein which will drain the anterior cord in the thoracolumbar region and can originate anywhere between T11 and L3. The problem arises when you can be confused between the great anterior radiculomedullary vein and the artery of Adamkiewicz. So there are ways to differentiate between these two. The GARV is usually lower than the artery of Adamkiewicz would be. It is going to be a little bit more tortuous and serpentine. It has a longer intradural course and it has a larger caliber than the artery of Adamkiewicz. And if you do have angiography, then it will be very obvious because it will fill later on angiography because it is a vein. Right. So the meninges and the spaces of the lumbar spine are more or less similar. You have the subarachnoid space, but the pia mater of the conus medullaris does form an important structure here known as the filum terminale. The filum terminale has an internum and an externum part. The internum part is going to extend up till the lower border of the thecal sac, that is the S2 level. Beyond that, the filum terminale will continue along with dura and arachnoid and attach at the level of the coccyx, and that is known as the filum terminale externum. The within the subarachnoid space of the lumbar spine, everything is located more posteriorly, unlike what we were seeing with thoracic spine. So here the ventral subarachnoid space is going to be a lot more obvious than the dorsal subarachnoid space. The nerve roots are going to exit through the neuroforamen along with dural sleeves. Now, since the L1, L2 nerve roots exit more or less horizontally, the dural sleeves are quite short usually, and as the nerve roots are going down, the dural sleeves become longer and longer, and they become more angled inferiorly rather than outside and obliquely. There can be some important dural sleeve variants, the most important one being a conjoined nerve root. That is when two nerve roots exit through a common dural sleeve. This most commonly can happen at L5S1 and that can be problematic during surgery. Sometimes what you can have on the other hand is that two spinal nerves have separate dural sleeves but are exiting through the same intervertebral foramen. You also have these epidural fat pads, which are also again very prominently seen in lumbar spine, the interlaminar epidural fat pads. And as you can see, this is a triangular shaped structure, which is a fat pad. As we know, the mid-thoracic spinal cord is round, but as you go down and you encounter the lumbar enlargement, it will become more wide, but it becomes more wide in the transverse section. So that's not clearly seen on sagittal images. It will be better seen on the coronal image. The conus medullaris, which is the end of the spinal cord, usually lies at L1 to L2, but it can lie anywhere between T12 to L3. A conus lying below L3 is definitely abnormal and is a low-lying cord. If it is lying on the other hand at the level of L3, that's a little bit more indeterminate. You're not sure if it is abnormal or not. So we have to further evaluate to check for a tethered cord there. The conus sometimes can have a terminal ventricle known as ventriculus terminalis, and that is normal. Okay, and the chorda equina usually contains L2 to L5 and S1 to S5 nerve roots. The nerve roots positioned more centrally would be your more inferior nerve roots. The S2 to S5 nerve roots are going to be positioned more medially, while the nerve roots which are going to be exiting obviously are going to be positioned more laterally. And you can see this dorsal root ganglion over here. It's a very large structure located in the neural foramen. We can also make out the filum terminale sometimes in the images. So if it is appearing hyperintense on T1, that is abnormal. It should not appear hyperintense on T1. It means there's some fatty infiltration which has happened, and it's a fatty filum terminale. Now the normal filum terminale should not be thicker than 2 millimeters. If it is, then it is a thickened filum terminale, which can indicate there is some cord tethering present. It is also possible to image the lumbar spine in children below the age of 6 months because the posterior elements have not yet ossified. This is usually done to look for neural tube defects. As you can see in this ultrasound, the spinal cord, which is here, so this is a spinal cord. It appears more or less hypoechoic. The spinal cord parenchyma is hypoechoic, but the central canal is hyperechoic, and the border of the spinal cord is again hyperechoic. The nerve roots are all hyperechoic, and the subarachnoid space in CSF is hypoechoic. So when you don't have ossified posterior elements, you can see all these. Right, so that is about the lumbar spine. Can we identify these hidden structures seen on an X-ray? So this is an oblique X-ray, and what would this structure be? Right, so this is the eye of the Scottish dog. As again, let's just draw the dog so there's no confusion. Okay, so this is the dog. It is an oblique view, so it can look slightly confusing. You can see this, there are facet joints over here, and there are facet joints posteriorly, and that is on the other side. This is on one side, these are joints on the other side. Okay, so the Scottish dog is created by joining up all the facet joints on both the sides. The eye of the dog is the pedicle. And so what is this structure? This is the vertebral body. This is the pedicle. This over here is the pars interarticularis. Okay, and it is giving rise to the inferior articular process over here. And this is the superior articular process over here, which is going to form the facet joint with the inferior articular process of the vertebra above. This is the superior facet. Okay, so what are these structures? Okay, so these are small tubercles which arise from the junction of the transverse process and the pars interarticularis, known as the accessory processes. You have the mammillary tubercles or the mammillary process here, the accessory process here, and the mammallo-accessory notch which is present over here. Okay, so what is this? Well, this is a bit easy, it's already been labeled on the other side, but this is the dorsal root ganglion which is present within the neural foramen over here. Okay, that is all for today's lecture. Thank you so much for attending. If there's any questions, you can put them in the chat box or in the feedback forms we provided afterwards.